Hi, good night to everyone. Thank you all for joining us. It's a great pleasure to be here tonight, and we are having our final lecture in the Family Life Enrichment Series 2023. It was a pleasure having you over the last few weeks. We have been blessed and encouraged by a wealth of knowledge by all the presenters who shared. Just to remind you, we had Nutrition the Caribbean Way with Mariam Burnett, Understanding Love Language by Reverend Anderson Kelman. We also had a panel discussion on maximizing singlehood. We also had mental health under the microscope with David Johnson. And we also had Understanding and Coping with the Elderly by Trudy Rowe Weeks. Tonight, our topic is heart health. And when we think of the word heart, we know in the Bible, the word heart is mentioned over 800 times. And normally when we hear heart, we think of the seat of emotion. You know, something in your heart can be considered good or evil. Proverbs 4:23 reminds us to guard our hearts, for out of it flows everything you do. But tonight we're not talking about our spiritual heart, we're talking about our physical heart. And that beats hundreds and hundreds of times during the day. The health of our heart is a concern to all of us. Don't matter what age we are, we should be concerned about our heart. So we are delighted tonight to have Dr. Renee Boyce to enlighten us about how to maintain and how to keep a healthy heart. And at this time, Sister Kathy and Pastor Lloyd Burrows from the Manor Church of God, and Sister Kathy and Sober's Press, she's going to read a bio about Dr. Renee Boyce. So, Sister Kathy.
Blessed good night to all. Dr. Renee Boyce is a proud graduate of the University of the West Indies, class of 2004, where she received her MBBS degree, and subsequently a postgraduate diploma in family medicine in 2016. She is about to graduate with a master's in health care management. She worked in the Department of Hematology at the Queen Elizabeth Hospital before transferring to the Winston Scott Polyclinic. After working in the public system for over a decade, Dr. Boyce transitioned to private practice, where she currently manages her general medical practice. Over the years, Dr. Boyce discovered a passion for public speaking and teaching and has facilitated numerous lectures for churches and other social groups on various aspects of health. She has been a repeat guest on Morning Barbados and a past weekly columnist for the Barbados Today online paper and the Better Health magazine. Dr. Renee hosted the Better Health radio show on VOB 92.9 for over 4 years. She is a former public relations officer of the Barbados Association of Medical Practitioners, past member of the National Advisory Committee of Occupational Safety and Health, and currently is a facilitator of health lectures for parents of Barbados. She's an avid musician capable of playing 4 instruments and has been a keyboardist at her local church for nearly 30 years. She now heads the worship team at church. Despite a seemingly hectic professional schedule and a deep love for her patients, she maintains that her commitment to her family is her primary focus. She's been married for 17 years and is the mother of 2 children, ages 14 and 10. Dr. Boyce believes in striving for excellence in whatever one attempts, doing it as unto God, and it is her desire through continued discovery of her God-given purpose to empower others to reach their own destinies. Remember to place your questions in the YouTube chat. We are happy to have you. Welcome, Dr. Renee Boyce.
Welcome, Dr. Boyce.
Hello, good evening, everyone. Thank you so very much for the warm welcome. I'm excited about this evening's presentation. As I was given the topic, my mind started to race about all the things we could possibly discuss about the heart. And it was as though I was running a marathon because there are so many things to do with heart health. So this evening, we are only going to focus on things which I found in working as a physician, a primary care physician. These things seem to be the most important. And I say that guardedly because everything about your health is important. But these things that I'm going to share tonight, I think are the basis of a good foundation for understanding heart health and for understanding why your physician would do certain things or the particular things, and to help you to manage your own life better. And before we started, I jokingly said to the team that I am hopeful that my attempts at screen sharing will go as smoothly as they did before. So here we go. I am about to share my presentation and we will get into this evening's talk. And remember, your discussions, your questions will be the heart of this discussion, not the information that I am sharing, but what you will ask and the information that I'll be able to share. So I am double checking that you're able to see my first slide. It's crystal clear and we can, as they say, hit the ground running. Good to go?
Yes, it's good. It's good. Yeah.
All right, here we go. So we are getting to the heart of the matter. And as I heard my bio, it sort of dated me, because next year in July, on June 26th, it's going to be exactly 19 years that I have been a doctor. So next year, Lord willing, I'm looking to celebrate 20 years as a practicing physician. Don't let the face fool you. So this lecture it's intended for the sole purpose of education. Its creation is not to diagnose or treat any medical conditions. And I really would caution that if there are any symptoms that you have, that you should speak to your healthcare provider, a trusted healthcare provider. And that's whether or not your healthcare provider is in the private setting or in the public setting. Now we're going to start off with exercise. And this exercise is not going to cause you to have to move from your seats, but this is something that I want you to do. In the next 15 seconds, I want to see how many times you are capable of getting your heart to stop beating. In 3, 2, 1, let's go. All right, so that's just about 15 seconds and I'm not able to see the chat, but please put in the chat if there was anybody who was able to get their heart to stop beating. And Pastor Burrows or Sister Kathy, can you tell me if anybody put in the chat that they were able to get their heart to stop beating?
Not as yet.
Exactly. Now, you can hold your breath, you can stop breathing, and that there's so many reasons why you'll be able to do that. If you go underwater, if you're surprised about something, but believe you me, you don't want your heart to stop beating. I'm sure that there are Chinese practitioners maybe, or for medical reasons, of course, that when we think about heart transplantations and so on, we would want our heart to stop. But on an average day in run-of-the-mill functioning, you don't want your heart to stop beating. Trust me when I tell you that. So what we're going to cover tonight, we're going to look at the basic anatomy and physiology of the heart. And that means the structure and the way the heart works. And that big topic, hypertension, we're going to talk about what it is. We're going to discuss the symptoms and the causes. How does hypertension affect the heart? And certainly we want to talk about the management of hypertension. We also want to talk about another major crisis with heart disease, heart attacks. and we're going to talk about the symptoms, what puts one person at greater risk of a heart attack than another. And we're also going to speak about management. And these other topics will come up, I'm sure, either in the questions or towards the end of our session. We're going to talk about cholesterol, we're going to talk about stress, and there's some topical issues that we will discuss as well. So the heart is a muscular organ, and it's not on the left side of your chest, but it's actually in the center of your chest cavity. But what happens is that the heart points towards the left. And that's why most people think that the heart is on the left side of the body, but really and truly it's in the center of your chest. And the main purpose of the heart is to regulate blood flow. You need blood in order to survive. In the unfortunate event that somebody is stabbed in one of the major arteries or so, and they lose a lot of blood, this is one of the reasons why persons die, because they don't have a lot of blood left to carry out the functions which are necessary for life. What the heart does is that at one end of the cardiac or heart cycle, it pumps oxygenated blood to the body. On the other end of the cycle, it takes blood where the oxygen would have been used up by the tissues in the body, and it sends it to the lungs. The lungs put more oxygen in the blood, and the cycle repeats itself over and over. So we get oxygenated blood going to the body, oxygen is used up, so that blood comes back to the heart sends it to the lungs, and we repeat that over. That's our cardiac cycle. Now the heart is divided into 4 chambers, 2 at the top, 2 at the bottom, left and right. The ones at the top, they're called atria, single atrium, and the ones on the bottom, ventricles. And in between these chambers, there are valves that prevent backflow of blood. So when you hear about murmurs, one of the reasons why you can get murmurs is that there is abnormal flow of blood across these valves, in which blood is only supposed to flow in one direction. Now, it would make sense, therefore, if the heart is sending blood to other parts of the body for that particular structure to work, then the heart itself would need blood, and it has its own blood supply, coronary arteries, which are very important in heart health. The heart is also very unique in that it has its own electrical activity, which drives the function of the heart, because there must be something that's keeping the heart beating and beating and beating. So there's this special electrical tissue that's located, it starts in the right atrium. Remember, atrium is the upper chamber of the heart, and it beats steadily about 70 times per minute. Now this is variable, as we'll go on to discuss, but generally speaking, about 100,000 times a day, your heart is beating. And in most circumstances, you can't tell that your heart is beating. If you pause right now, you might become aware of your heart beating, but for the past 5 minutes, 10 minutes, you weren't aware or shouldn't have been aware that your heart was beating. Now, this is a model of the heart, and this would be our left ventricle, and the right ventricle is over here. This is the aortic arch, part of that great blood vessel, the largest artery in the body, the aorta. But this is just to show you, this is not to confuse you and make you contemplate life. This is just to show you how the heart really is made up and all the different connections and so on that go on in the heart. And here we have, where's the point? Here we go, the coronary arteries and coronary veins. We spoke about this electrical tissue of the heart, and it starts right here at the sinoatrial node in the upper chamber of the heart. And then we have another node, the atrioventricular node, which is right here, and it divides and divides into smaller branches so that it can supply the entire heart with this electrical activity. And this is the purpose of being able to understand the ECG. So you go to your doctor for an appointment, and he or she says, well, we want to do an ECG for, perhaps you might need it for medical, perhaps there is an abnormal rhythm of the heart, because one of the things that we know about the heart is that it beats steadily. 70, 72 times per minute, we have a steady beat to the heart. And this is shown very nicely here in this diagram. Nice and steady. They look nice and even, and they're well spaced, equally spaced. Now, if we look at the one on the bottom, Not to make cardiologists out of you tonight, but we can immediately see that there's something looking a little strange in these ones right here. They don't have this nice, precise, equal look as the ones above. And this is actually what can be seen sometimes in what we call a myocardial infarction, or simply put, a heart attack. So the scientists discovered that by putting metal plates on the body, it can actually pick up the electrical activity of the heart and give a very good indication of all the different things that are going on in the heart. So we say ECG here in Barbados in most cases, because we spell cardiogram with a C. Those persons who follow the US system, they say EKG because they spell electrocardiogram with a K. And just a little note, electrocardiogram is different from an echocardiogram. Echocardiogram in simple terms would be like an ultrasound of the heart, as opposed to looking at the electrical activity of the heart. Now, the heart isn't entirely self-regulated. So many things can influence it. If somebody jumps you, your heart rate is going to go up. So hormones affect your heart rate. Things like adrenaline, cortisol, thyroid hormone coming from your thyroid gland. There are lots of effects from drugs on the heart, both legal drugs and illegal drugs. So illegal drugs are not safe. And I'm sure there's somebody who is saying legal drugs aren't safe either, but we'll get into that later. Other medical conditions can impact on the heart, such as lupus, like an autoimmune condition, and your general state of health really does have an impact on your heart. Now let's look at hypertension. Hypertension here in Barbados, we say pressure or high blood pressure is when your blood pressure, which is the force of blood going through your blood vessels, is consistently too high. And this is a simplified way that the American Heart Association has defined hypertension. If you think about it like a pumping station and then it divides into the smaller pipes going all the way down to your home, this is the way to look at the heart, and then the arteries getting smaller and smaller going to the different parts of your body. Now, the National Institutes of Health, they put a number on it. When your blood pressure is consistently greater than or equal to 130 on 80 millimeters of mercury, that's hypertension. Now, we have our first quiz, and you're going to have to put your answers in the chat, and I want you to do it very quickly. Put those answers in the chat. I sound like one of those persons on the YouTube videos. What is the most common symptom of hypertension? Is it headache? Is it pain at the back of the neck, blurred vision, nausea and vomiting, or dizziness? What is the most common symptom of hypertension? And we're going to ask again, Pastor Burrows or Sister Kathy, to tell me what answers we're seeing there in the chat.
Okay, nothing as yet. Okay. I think they're off to a slow start.
Oh, that's quite okay. Well, let me ask you, since you are in the medical field, Pastor Burrows, what do you think is the most?
I would say nausea, vomiting.
Nausea, vomiting, okay. You want to take a guess, Sister Kathy?
I would say headaches.
Headaches. Okay, and one more
Somebody
glance at the chat.
Someone, Joan says, Bishop, pain in the back of the neck.
And we have 4 persons saying headaches, 5 persons saying headaches so far.
Okay. So we have headache, we had nausea and vomiting, and we had pain at the back of the neck.
Somebody said none of the above.
We are going to go with, we're going to go with none of the above. The most common symptom of hypertension is none. None. No symptoms. Hypertension is quite often asymptomatic. By the time you are experiencing a headache as a result of hypertension, you are in some significant danger. So those persons who would come into the office and say, I know that my pressure is up because I'm getting pain at the back of my neck, or my head is hurting me, so I want to get my pressure checked because I think that that's why my head is hurting me. That's not correct at all. Most persons discover that they're hypertensive on a routine visit to their doctors, and they would have been feeling completely well. And I will very quickly share a personal experience. We were taught in medical school that when you are sharing, you're talking to patients and whatever else, you really don't say anything about yourselves. But I believe, more importantly, that patients are able to relate a little better when they view you as human as well. After I had had my second child, I was supposed to get my follow-up with my doctor. For some reason, it was put back, and then a space opened up. And a few days prior to that, I remember saying to my husband, I just feel a little unwell, but you just had a child and so on. You're thinking that you're tired because of whatever else. So I go to my doctor and she checks my blood pressure. And then she says, well, she raises an eyebrow. And then she says, let me do this again. And the second time she did it, she told me that my blood pressure was 220 on 110 millimeters of mercury. Now, if you think back to what I just said about the diagnosis of hypertension being 130 on 80, and I was at 220 on 110, you could understand why I started feeling unwell and started feeling a bit dizzy and not there. 220 on 110 is asking for a stroke. So remember, no symptoms. That would be the most common symptom of hypertension. And let's look at Barbados very quickly. We are well on our way in this presentation. This was taken from PAHO in 2016 in one of their papers that they had written. And it says, the outwardly calm and relaxing Caribbean island of Barbados hides a pressure cooker health crisis. More than 1/3 of Barbadians aged 25 to 70 years suffer from hypertension. And the important thing here is, apart from those things which are bold, is that it is the main risk factor for cardiovascular disease, the world's #1 killer. And we are sitting down with more than 1/3 of the people 25 to 70. So 25 to 70 would be our young people, our working force, or our workforce, and those persons who would have just entered retirement. Wait a minute. No, this is our workforce because retirement is now age 70. So this is our working population, age 25 to 70. Think about that. Now, these numbers might look a little confusing, but what I want to bring home to you would be this right here. 50% of women age 65 and over, their high blood pressure is not controlled, as opposed to 43% of men. Now, this might have to do with health-seeking behavior in men, knowing that the men don't go to the doctor, so that could be a possible reason. And also, one of the side effects of the hypertensive medication, antihypertensive medication, is loss of erections. So most men do not take their hypertensive medication, antihypertensive medication, for that reason. So that's why in most cases they're not controlled. Prevalence is how much of a disease exists in the community at one point in time. And here again, that 65 plus bracket of women, 81% of women have hypertension. And this was taken from the Health of the Nation survey. This was back in 2011. And we know that things have gotten worse since then. So why bother about hypertension? Why come and talk about this? Why? Because in Barbados, we get 14 strokes a week, 10 heart attacks a week. There is visual loss as a result of uncontrolled hypertension. Heart attacks we're going to talk about right now, and heart failure. These are all things that result from blood pressure that's not controlled. When persons have their blood pressure machines at home and you ask them what their blood pressure readings are, they're not sure. You come into your doctor's office and he or she takes your blood pressure and they say, these are your numbers. But in most cases, those are just numbers that are being given to you and you don't understand what the numbers mean. So let's briefly go through this. If your blood pressure is normal, and these are just two groups, this would be the Joint Committee on Prevention, Detection, and Evaluation and Treatment of High Blood Pressure, and then the American College of Cardiology and the American Heart Association. Now, they both say when your blood pressure is 120 on 80, but it's less than that, that's normal. Now, the seventh report, they say 120 to 139 systolic, which is the one on the top, that puts you at risk or pre-hypertension. Whereas the American College, they're a little more cautious, 120 to 129. And certainly for that definition of hypertension, where the Joint Committee, they say 140 on 90 and higher, that's for hypertension. But the American College of Cardiology, they're saying, no, we're not going to wait until 140 on 90. We are going at 130 on 80 for that definition of hypertension. So this is your typical blood pressure machine. You're all gung-ho about having gotten your machine. Your doctor tells you, I want you to record your blood pressures at home. Systolic, which is the reading on top. This is when the heart contracts. Diastolic, which is the one on the bottom. This is when the heart relaxes. And the figure on the bottom is the heart rate. So when you have your machine, this is what the readings mean. Systolic, diastolic, and the pulse rate is 85. So this person's blood pressure is 138 on 100. And by both definitions, this person has hypertension. Now, the other thing about the blood pressure machines at home is that in order for your readings to mean something, your blood pressure readings should be done in a particular way. It should be done in a particular way in the office, but especially at home, so that your readings make sense. The purpose of carrying out a test is so that when you get back those readings, be it a blood test, be it an ECG, be it a stress test where you're running on a treadmill and they're recording the activity of your heart, you want to be able to act upon those readings, which means that you want the readings to be valid. So first of all, you're not supposed to be quarreling with the children when you're taking your blood pressure. That is going to add 10 millimeters of mercury minimum. And if you're arguing and quarreling, I'm certain it's more than 10 millimeters of mercury. So certainly that will slide you into hypertension. We're all different sizes, and machines come with the appropriate size for the size of your hand. So if you imagine somebody that weighs 300 pounds, but you're using the cuff for somebody who's, let's say, 120 pounds, that cuff is going to be so tight for that person who weighs 300 pounds, and therefore their reading is not accurate. The cuff is supposed to be on your bare arm. So just because I don't feel like taking off my clothes, but I just want to measure my blood pressure, I go and I slide the cuff on over my shirt, I'm going to give myself an additional 50 millimeters of mercury, and certainly probably give myself a stroke when I see that reading. You're supposed to sit with both feet flat on the ground. And I laugh at this because there are some chairs that certain people of certain heights, when they sit in doctors' offices, their feet swing. So as much as possible, see if you can sit somewhere where your feet can touch the ground, where your back is supported. You're not supposed to have any caffeine. You're supposed to empty your bladder, because that's another 10 millimeters of mercury. And if you think about it, if your bladder is full, you're not comfortable, you're tense, and you are stimulating those stress hormones. All right. And you try to keep your legs uncrossed, and certainly keep your arm at heart level. Some people ask whether or not you should do it in the right or in the left arm. The blood pressures in the arms should be pretty much equal. So depending on where your support is, you might have to do it in one arm and not the other, but you must be consistent. And if you do find that there is significant variability, meaning that there's a big difference between one reading in one arm and the other reading in the other arm, then you should really seek your doctor's attention. So we normally say disregard the first reading. Some people get very tense about doing their blood pressure and so on. And then you repeat the blood pressure maybe after about another 2 minutes, and you record that. And ideally you should do it morning and evening, going through the same steps. You keep a log of your readings so that you can discuss with your doctor those readings and therefore come up with a plan about managing your blood pressure. Let's segue into heart attacks and another quiz. What are some of the risk factors for heart attacks? This is to make sure that you are still listening. So quickly, let's put those in the chat. Risk factors for heart attacks. What makes me more likely to get a heart attack than somebody else? Any answers as yet?
Not as yet. There's a
All right.
20-second delay.
Oh, thought about that. So we're going to wait for some of those answers from our participants.
Just now when I answered your question, I was thinking of a heart attack. That's why I said vomiting.
Okay, okay.
So I was like, those students not hearing the question properly.
Yes, that's the problem that teachers have, getting children to read instructions. All right, well, let's move
We have
on.
high blood pressure. So
Yes.
Sherman Jordan, high blood pressure. And a second person, Cutter, high blood pressure.
Major risk factor, major risk factor. Any others?
Not as yet.
All right, well, I will reveal the list. Hypertension, diabetes, obesity, elevated LDL levels, and we'll go on to talk about LDL in a little bit. Smoking, and not only smoking, but exposure to secondhand smoke. So even if you are not the one smoking, if you live in close proximity to persons who are smoking, then that puts you at risk for developing a heart attack as well. Certainly an unhealthy diet, a sedentary lifestyle, and if you have underlying heart disorders, then that puts you at risk for heart attacks as well. But if we look at these risk factors here, all of the risk factors I have listed are modifiable except for underlying heart disorders, because that might have been something that you might have been born with. But all of the others are modifiable, which means that you can change your risk for developing a heart attack, or perhaps I should say a person can change his or her risk for developing a heart attack. Now, when we talk about a heart attack, remember when we looked at the diagram earlier of the structure of the heart, we mentioned that the heart needed its own blood supply, the coronary arteries. And if one of these arteries becomes blocked, the tissue that is supposed to be supplied by this artery doesn't receive oxygenated blood, and therefore it dies. And the severity of the heart attack depends on how much of the heart is affected by this blockage. And one of the other things is, even if a person doesn't die as a result of the heart attack, which is one of the causes of sudden death, then you, the individual, lives with long-term effects of the heart. The heart is the only muscle in the body that I can think of whose function does not improve as it gets bigger. So we go into the gym and we work out and we build biceps and we build quads and so on. And these muscles become more efficient. They're better at burning fat. They help you to maintain an erect posture and you can carry load, but a large heart is inefficient. So let's talk a little bit about cholesterol, one of these topical issues. Everybody is talking about their cholesterol. Doc, what's my cholesterol? I need to get my cholesterol checked. There are people who are doing random checks of cholesterol for health fairs and so on. So cholesterol is very important. It's a waxy fat-like substance and it's created in the body, found in the cell walls. And cholesterol is not all bad. There are high levels of cholesterol in the brain and spinal cord tissue. And cholesterol is necessary for the synthesis of vitamins and hormones and normal bodily functions. But the problem arises when we have too much of the bad cholesterol, which we know to be the LDL, low density lipoprotein, and the VLDL, very low density lipoprotein, whereas the good one would be the high density lipoprotein. And we are also concerned about levels of triglycerides. So these are the things that are measured when you go to get your blood test checked. Now, medicine doesn't agree on everything. So in the past, you were always told that when you have to go and get your cholesterol levels checked, that you shouldn't have a meal. There are some quarters who say that that's not absolutely necessary. It would only become relevant if you've had a massive meal with lots of fats and oils and something that would really carry up your triglyceride levels. However, the preference is to err on the side of caution. So if you are sent for a cholesterol test, try not to eat anything. And I realized very early in my career that you really had to define what fasting is. So we would tell persons, well, fast for about 12 hours. So let's say you have to take your blood test at 8 o'clock in the morning, and you tend to go earlier in the morning when you're doing a fasting blood test. That means nothing to eat. Nothing means nothing that has calories, I should say. So you can have tea without sugar, you can have water, but you are not supposed to suck on mints. You are not supposed to nibble on 2 biscuits. Nothing means nothing. What the advice that I usually give to my patients is walk with your breakfast. Get the test done and sit down and have your breakfast before you go on to work or whatever else you have to do. Again, you do a test because you want to get back numbers so that you can know what to do about your life. So we have like a traffic light, the red light, the orange light, and the green light. So let's just look at one, for example. Let's look at the LDL. Now in the United States, they use milligrams per deciliter. Our units are different. We use millimoles per liter. So you would hear persons from America talking about, yeah, my cholesterol is less than 200. And when we in Barbados hear that, I'm like, oh, that's great. It should be, but the units are different. So for us, where we want the total cholesterol to be is less than 5.2. And we want the HDL to be high. So if it's greater than 1.55, wonderful. And for the bad cholesterol, the LDL, want that to be less than 3.36. So this chart, which can be found in your doctor's office, it can be found on the internet, gives the ranges of where your cholesterol levels are, and it gives you an idea of what needs to be done in order to reduce your risk for heart disease. So let's talk about heart management. So again, let's put the scenario where you are going to your doctor's office and he or she has discovered that there are some changes perhaps on an ECG, or you've done your cholesterol tests and realized that your LDL, the bad cholesterol, is a little high, or you've done your blood sugar and you are tiptoeing across the border of normal and pre-diabetes, or you're on the other side of pre-diabetes, just tipping over to diabetes. You go into your doctor's office and you hear about, it's not too late. We can still do something about this. We need to increase your physical activity, reduce your sugar and salt and fat. You need to control your blood pressure and control your blood sugar. Make sure you take your medication and reduce your stress levels. Now that's ineffective. It's just telling you broadly the areas that need to be adjusted, but you haven't been given any tools to make those changes and to make them sustainable. Ideally, what is necessary for heart management is a team-based approach. Each of us is individual. We have different needs. We might have the same blood pressure of, let's say, 140 on 90, but your risk might be different from mine, or an individual's risk might be different from another's, based on the fact that that individual also has diabetes, or perhaps that individual has renal disease, kidney disease. So the risks are different, and the plans that should be put in place for one individual don't necessarily mirror the plans that should be put in place for the other individual. So the care plan must be individualized. The team-based approach. The reason why there are subspecialties in medicine is that persons pay plenty of money to go and further their studies. So persons, they branch off and they become nutritionists, other persons become cardiologists, and so you get the point. People specialize so that they're better able to monitor and manage an individual's health. So the input that can be gained from a cardiologist in managing hypertension, and we think that we should go to the cardiologist after you've had your heart attack. An individual has had his or her heart attack, and that's the only time you should go to the cardiologist. But no, you could go to the cardiologist before that, have a relationship with your cardiologist. Here in Barbados, that's not the arrangement at present, but certainly in the future, that's where we would like to go, where we can have the input of the cardiologist into preventive heart health. The nutritionist, certainly the nutritionist, the endocrinologist, the person who manages diabetes and pre-diabetes. So when you get valuable information and the different nuances that these people will be able to put in your management plan, certainly the outcomes would be better. And I always say, if you leave your consultation with your doctor or other healthcare practitioner and you are none the wiser about your health diagnosis, about what the plan is, what the expectations are, you need to change your healthcare provider. And the plan is not static. It's similar to working out. So you start to work out and these are the exercises that you do, but with time you become fitter. So if you've gone through your workout program and you started being unable to lift 10 pounds and now you can lift 10 pounds with the little finger, even although this is my index finger, but you can lift 10 pounds with a little finger, then certainly your trainer or you yourself should increase your weight. And therefore, the plan for managing your heart health changes with time. It changes with age. It changes with stage in life. Perhaps in one particular stage of life, you're pregnant. So the drugs you may be taking would have to change. Your hypertension may become worse as a result of pregnancy or may be induced as a result of pregnancy. So the plan changes, or you might be under severe stress in a very, very stressful job. So that's the important thing, an individualized plan, a team-based approach, and it evolves with time. Oh, and I forgot the most important part, that you, the patient, you're the center of this plan. So your desires within reason are the most important. What you understand, what you feel, what you think, where the deficiencies in your understanding are, these are the important things that need to be addressed. So a few recommendations. Any changes that you want to make in your lifestyle, you need to get the, I nearly said permission, but that's not the word, advice of your healthcare provider, advice. Don't get up and go and run across the garrison saying, you know what, doctor say I need to lose some weight, and therefore I am going to get up and go and run 2 laps around the garrison. Those might be the last 2 laps that you run in life. Start small. And again, I go back to running around the garrison. If you have not exercised, today being the 14th of June, and you have not exercised a bit since the 1st of January, I wouldn't recommend running around the garrison. And if there are persons who are joining us who don't live in Barbados, the garrison is where we would have horse racing, but it's also a place where persons go to exercise. It's a very, very big playing field or horse racing track. Lots of grass there for exercising and some exercise equipment. So the individual who has not exercised in 6 months should not attempt to run 2 laps around the garrison. No, you start small. What you're looking for is consistency. So if in the first day you could only manage, I don't know, a furlong. I don't know how much a furlong is. I just hear it on horse racing. If you could just manage 1 furlong, well, then that's what you can manage. And you keep doing that until you recognize, oh, wait a minute, I finished faster than I did the last time, or I've walked more than a furlong, and therefore you step it up gradually. You need to find out what works for you. For years, I have been trying to learn how to swim. I have not succeeded. Therefore, I cannot tell my healthcare provider that I am going to lose weight by swimming. It can't work. People say that, really and truly here in Barbados again, we have lots of open spaces and we have neighborhoods which have been nicely built up, and you can walk around your neighborhood. That works for you. It doesn't work for another individual who gets bored of seeing the same buildings all the time and just walking around in a circle. So you need to find what works for you. And another thing is that you cannot be bullied by other persons who should tell you what you should do. Oh man, yeah, I did this, I joined this gym and this is good for me. It doesn't work for you, then you don't do it. You need to take time to get adequate rest. So again, that plan of getting up and deciding that you're going to go, and I'm going to go to the gym every day and I'm going to walk every day at 5:30 in the morning. No, you need to rest, right? And you celebrate small victories. Please don't celebrate the small victories with unhealthy food. Go and binge eat. So I exercise 5 days in the week, or 3 out of the 5 days of the work week. And then on Saturday, so you know what, I exercised and I think I did a pretty good job. I think I should go at the rum shop and get me some fried pork and chips and a rum. You've just blown everything that you did in that week. So celebrate the small victories. Perhaps you should buy a gym shirt or an exercise shirt, or buy yourself a lipstick, or do something relaxing. But understand that changes take time. Changes take time. So you did not put on 200 pounds in 6 weeks. You are not going to lose 200 pounds in 6 weeks. Not healthily, definitely not healthily. Changes take time. You need to find an accountability partner, and you must make sure that your accountability partner is going to keep you accountable. So if your accountability partner has a weakness for chocolates, you're not going to use that person to keep you accountable with your sweet tooth. That makes no sense. So you need to find an accountability partner. But some more defined recommendations. This is from the American College of Sports Medicine and from the Centers for Disease Control. 150 minutes per week of moderate intensity aerobic exercise, walking, running, jogging, skipping, gardening, any of those. And 2 times in the week, you should do muscle strengthening activities. And these can be done with additional weights. They can be done with resistance bands. They can be done with body weight. And you're trying to work all the muscle groups. All right. So these are just some of the general recommendations. In terms of dietary guidelines, there are many guidelines available online. Here we have from our National Nutrition Center a published set of guidelines to tell you what foods are in each group, to tell you how much would make a serving. It also speaks about reading labels, which is very topical here in the country. So you can download the guidelines, I believe, from the National Nutritional Center's website. You must be cautioned about trying to download a meal plan online. Remember, I said it's individualized. So be very cautious about trying to get a meal plan online. Now I have here cholesterol lowering foods. So it's not a food that you're going to eat and it's going to lower your cholesterol like that. Some of them work by one, like the oats and barley and other grains, and the fiber supplements, and the apples and strawberries and citrus, like these ones, they're high in pectin, which is fibrous. So the fiber, the soluble fiber, it acts like a gel in the intestines. It slows down digestion, and what it does is that it mops up the bad cholesterol, and therefore it lowers the level of your bad cholesterol. In nuts and those foods which contain sterols have a structure similar to cholesterol. Earlier up, I had shown a slide which did outline the structure of cholesterol. So what happens is that these sterols are viewed by the body as cholesterol, and therefore the bad cholesterol isn't picked up by the body as much as the sterols, if that makes sense. I hope that makes sense to you. So it's almost like the mechanism for getting the cholesterol into the body. They don't pick up the cholesterol, the bad cholesterol, they pick up the sterols. And we talk about fatty fish. towards the end, we're going to talk about omega-3 fatty acids and so on, and topically, the fiber supplements. Everybody's talking about fiber, but the general recommendation is that try your best to get your nutrients from what you eat. Let's talk a little bit about drugs as we begin to wind down. Yes, drugs are substances which have an effect on the body, and the body has an effect on that drug. All drugs have side effects. And when I say drug, I mean alternative drugs. I mean those that are manufactured. All of them have side effects. The important thing is that you need to understand how to read a drug label. One of the biggest causes for persons not taking medication, and I'm sure some of you have said it, is that you read the side effects and you decided that this drug is not for you. Very quickly, side effects are listed in order of occurrence, the frequency of occurrence. So you would have listed the most, those side effects that occur most often. And then way down at the bottom, you would have those rare side effects that don't occur that often. So let's say I manufactured a drug, let's call it drug RB. And one of the major side effects that happens when you take this particular drug is that you feel nauseous and you get a headache. And one person who took the drug out of 250,000 persons, the nail on their fifth finger turned black, 1 out of 250,000. That has to be listed as a side effect because it happened to some person who took the drug. However, 1 out of 250,000, this particular thing happened to. So an individual is going to read the side effects, headache, okay, nausea, okay, that's no problem. Wait, my fingernail is going to turn black. Oh no, I'm not taking that drug, ignoring the fact that it was 1 in 250,000. So you need to discuss the side effects with your healthcare professional. And again, remember, I mentioned that one of the reasons why men tend not to take the antihypertensives is that it causes them not to be able to maintain or sustain erections. And therefore, they don't take it. I remember when I was studying overseas at Mona, the men say, cut them speed, but now take it. So they were not taking the antihypertensives, and many of them developed complications for uncontrolled hypertension. Let's talk a little bit as we wind up about alternative medications, a very, very topical issue. And let's talk about red yeast rice. It's yeast grown on rice, and the Eastern cultures, they use this in their meals, and they've been using it for medicinal purposes for centuries. It contains monocholine K, which is also the active ingredient in the commercial lipid-lowering drugs, and it's indicated for elevated cholesterol and heart disease. It works by lowering the triglyceride and LDL, which are the bad cholesterols, and it has the same side effect profile as the statins, the ones that are advertised on the television, and you hear the side effect profile. The most common ones being effects on the liver as well as muscle pain. So something that's alternative also has similar side effects as something that has been commercially manufactured. Another one is hawthorn berries, and persons use the leaves, the berries, and the flowers, and it's thought to improve heart health. It dilates the blood vessels. So it would be good to dilate the blood vessels because that means increased blood flow to the arteries. It's used for chest pain, heart failure, and managing high blood pressure. It's also used for anxiety and treating sores. And it's also used to treat any conditions where there are high levels of free radicals, whether it be stress, whether it be illness, and doses of up to 1,800 milligrams for about 16 weeks. And I spoke to you about the persons reading the labels in their medications. Another thing is the importance of studies. When you read information about a drug, you need to read it with a background of having understood what the studies are. Now, one of the studies that I saw for hawthorn, it says taking this particular dose, 2.3 milligrams per pound, significantly reduced the thickness of harmful plaque in the carotid artery. Carotid artery is the large artery that goes up into the neck. Now, when we see words like significantly reduce the thickness, harmful plaque buildup, and we run and we say, oh, well, yes, this is wonderful. But this study was only 64 people, which means that the number is too small to be generalizable for the population. What these studies can do is show where further study is necessary. And then we can say, well, yes, hawthorn can be used. Mind you, there are people who are using it and it's working for them. Again, that discussion to be had with your healthcare professional. The omega-3 fatty acids lower blood pressure, and the other side effects that you see there, good for memory and cognition as you get older, that would be good. And they contain DHA, EPA. These are the fatty acids which carry out these functions of increasing the HDL, the good cholesterol, and reducing the triglycerides, but it doesn't have an effect on the LDL. Now, the American Heart Association recommends that everyone eats fish twice a week. The American Heart Association doesn't live in Barbados. So the recommendation is that you look for alternative sources of your omega fatty acids, which can be found in things like chia seeds, other fish like mackerel and sardines, those fatty fish. The very big slab of salmon there might not be something that we're able to eat twice a week, but you get the idea. You look at your resources online and you see which are the foods that are high in these omega fatty acids, and you choose those and you make sure to incorporate them in your diet. Now, this isn't necessarily heart health, but this is another topical issue, and probiotics, because we hear the ads about the omega fatty acids, about probiotics. So these are live organisms and they're intended to be beneficial. And those are the common groups there, the lactobacillus and the bifidobacterium, found in yogurts, they're found in supplements. And it's thought that they positively influence the body's immune system. And after you've had diarrhea, for example, if you've had to take antibiotics or if you had gastro, we can use these probiotics to try to restore the microorganisms in the body. There's lots of study going on now about the microbiome, the particular makeup of the microorganisms within the body. So that's another topical area of study. And you have to be cautious if you're immunocompromised. And it's not only HIV that's immunocompromised. Those persons who have cancer and are on chemotherapy, those persons who have autoimmune diseases and they're taking steroids, for example, high doses, persons receiving chemotherapy, or persons who were born with deficient immune systems shouldn't take probiotics because of the risk of infection. And there may be the problem with antibiotic resistance, where the organisms develop mechanisms to evade the antibiotics that are given, and therefore infections aren't treatable. And we have gotten to the end. It might have seemed as though it was a lot of information, but we'll discuss in the questions. So as we found out from the beginning, the heart is very important and we can't live without it. Many adverse conditions can occur, and there are many risk factors for heart disease, many of which are modifiable. That means there's something you can do about those risk factors. And we listed them: having hypertension, having diabetes, elevated levels of cholesterol, sedentary lifestyles, smoking, and being obese. They're modifiable, they can make a difference. When you lose weight, when you adjust your diet, there are so many positive benefits. There are many alternative medicines that are in use, that are being studied, have been studied. Persons are using them with good results. Persons are using them safely. And again, the caution will be with both the commercial medications as well as those alternative medications, that you should have a discussion with your healthcare provider, be it your pharmacist, your generalist, your internist, anybody. Have that discussion about the medications. And recently I encountered somebody who had swelling of their feet. Yes, they had swelling of their feet, and they took a diuretic, which I know should only be taken after you've had a prescription for it. So this person was able to go to a pharmacy and buy that particular drug and then give it to somebody else. We can't take those risks in this day and age, all right? So for many of the alternative remedies, discussion and research is needed. So if I had a grapefruit in my hand, there was a recent video with someone speaking about the fact that for hypertension, if you can't mix the cholesterol medication and a blood pressure medication with grapefruit because your blood pressure would drop, then shouldn't we be taking the grapefruits for high blood pressure? Okay, that's reasonable. How many grapefruits? How often? How much of the active ingredient is in that particular grapefruit? So the issue is not whether or not we should be looking to natural sources. The issue is the safety. So we've studied commercial medications, and I'm not purporting that you should only take commercial medications. Let's just put that out there. But what I'm trying to get you to see is that we need to be safe, evidence-based medicine. So as a result of doing this, this is what happens. You take this, this is what happens. And once we have this and we're satisfied that it can be repeated, then go right ahead. But I go right back to my disclaimer at the front, have that discussion. And as I end, taken from Hebrews 12:12-13, therefore lift your drooping hands and strengthen your weak knees and make straight paths for your feet, so that what is lame may not be put out of joint, but rather be healed. So this brings me to the end of my presentation, and I am looking forward to answering your questions in the time that we have left.
Thank you so much, Dr. Boyce. I have a question here for you. The first one is the dangers of too much alcohol causing an enlarged heart. Have you any cases of men, on Friday evening, Saturday, drinking so much alcohol that some of them get enlarging hearts? Have you ever had experience with this?
Yes. What happens, we call it a cardiomyopathy, where remember I said earlier that the heart is one of those muscles, not one of those, is the muscle that when it gets larger, it does not function well. The cardiac cycle would be a part of the cycle is where the heart muscle contracts and then it relaxes, contracts and then relaxes. But a muscle that has undergone the toxic effects of alcohol is no longer able to perform that squeezing function as it should. It's weakened, it's destroyed. The fibers that make up the muscle are not effective, and therefore you get cardiac failure, heart failure as a result. And those persons who are alcoholics, you can tell them by how their face looks. They have the fat, round cheeks. They have what we call alcoholic faces, that facial look that's typical of persons who drink alcohol. Men tend to get gynecomastia, where they develop fatty breast tissue. And of course, everybody knows that alcohol does mash up your liver. And the problem in Barbados really is not the everyday drinking. The bigger problem in Barbados, and I'm certain culturally in many of our Caribbean islands, is the binge drinking. You see that Friday, Saturday, Sunday morning drinking? That is what gets us in trouble. Of course, the everyday drinking as well, but certainly the binge drinking is one of the big problems we have when it comes to misuse of alcohol. So yes, we get dilated hearts as a result of the toxic effects of alcohol.
Okay, thank you. One other question. You talk about high blood pressure medicines causing erectile dysfunction. And there's some that a doctor would use in cases where this is causing the problem. Can't you doctors use other medications that would not cause erectile dysfunction that will help lower your blood pressure?
Right, so the underlying principle of erections is that you need pressure to sustain the erection. You also need a beating heart to sustain an erection. However, the thing about medications is that they work in different ways, and they work on different parts of the blood vessels, they work on different parts of the heart, they work on different parts of the kidney. And doctors have found that there are some medications which are more likely to cause erectile dysfunction than others. Bearing in mind that the only reason for not getting an erection isn't the medication, because there is the emotional component to an erection, as well as the physiological or the body mechanism to an erection. And in many cases, when a gentleman gets diagnosed with hypertension, that plays on his mind. You get medication and you know about the side effects of the medication, that plays on your mind, emotional distress in a relationship, all of these different things. And it goes right back to my one of my former points about having that discussion with your doctor, ideally, or other healthcare provider. Ideally, you should never just stop a medication, except in the case where it causes a severe allergic reaction. If you take a medication, you realize that you can't breathe and you break out in hives, certainly you should not take that medication again. But the other manageable side effects, have that discussion. Doc, you gave me this thing to take, and really and truly, it's not working for me. I remember I had a patient, she was a female, 70-something years old. She had a younger spouse. He was in his late 40s, and we put her on steroids because of the underlying blood disorder she had. And the steroids were causing her vaginal ulcers, and she came right back with the steroids, and she's like, no, these are cramping my style. They're not working for me. I need something else. And we were able to figure out something else to give her. So certainly there are alternatives. Don't suffer in silence. This is one of the big problems. I firmly believe in consultations, there's not enough discussion. The purpose of going to your doctor is not just to go because you're supposed to go. You're supposed to come away having learned something, having solved a problem, right? So discussion.
Okay, thank you. I think Kathy has a question.
Yes, good night. I do. Joan is asking, what about dancing for exercise?
Certainly. Dancing is a wonderful form of exercise. We go back to the American College of Sports Medicine, their recommendation of 150 minutes per week of light to moderate aerobic activity, and dancing is included in that list. Anything that gets your heart pumping and it causes you to break out in a sweat, that is good exercise. And whilst I mentioned breaking out in a sweat, if you're exercising and you have broken out into a profuse sweat, the sweat is pouring off of you and you're getting chest pain and finding it difficult to breathe, then that is not necessarily a good thing. And perhaps you should seek, not perhaps, you should seek urgent medical attention.
Okay, thank you. Marcy is asking, is the swelling of feet a sign of heart failure?
There are several causes for your feet swelling. Two of the common causes would be heart failure, yes, because remember we spoke about the functions of the heart receiving blood from the body, and we spoke about the heart having valves which only allow blood to flow in one direction. Now, if you have a heart which has failed, and when we speak about heart failure, we talk about the heart being unable to fulfill its functions, which would be to provide oxygenated blood for the body and to receive deoxygenated blood and to pump blood to the lungs. A heart that is unable to do that for whatever reason, that's heart failure. In the case of left ventricle, which is the left bottom chamber, that has been destroyed. Let's say there was a heart attack and that chamber is no longer able to pump in the way it should. That means that the blood pools in the heart and it backs up. And therefore, blood that should be collected from the legs and go back around the body, it doesn't get to do that. So you end up with leg swelling. That's a simplified way of looking at it. Another common cause of leg swelling is what we call venous insufficiency, where the veins in the legs now, the valves in those vessels, they allow blood to backflow. So instead of the blood being sent back to the heart, it stays and it pools at the ankles, and the severity depends, the amount of swelling depends on the severity. And you find for venous insufficiency, if you elevate your legs, the swelling goes down. Not to say that the swelling from heart failure won't go down either, but that's one of the things that we tend to ask about whether or not the swelling goes down. And there are other causes. So any of the major organs like the liver or kidney, if they're malfunctioning, they can also cause leg swelling. So if you have leg swelling, you should go and have it investigated. And the earlier that it's done, the more likely there would be a positive outcome.
Thank you. I have another question for you. Mardell is asking, and ECG shows that you have an enlarged heart. Does the heart remain enlarged or can it return to normal size?
It remains enlarged. It remains enlarged. It doesn't go back. So the emphasis, therefore, is on trying to reduce further enlargement. There is something called remodeling of the heart. The structure of the heart changes as a result of damage. And I would say that it goes back. I think the treatments stop it from worsening, stop it from getting those permanent changes where the function just keeps getting worse and worse. The structural changes that keep getting worse and worse. So if your heart, and you can also see it on a chest X-ray, for example. So if the ratio on a chest X-ray is, let's say, 2:1, and something happens and it becomes 3:1, for example, these are just random numbers. If you keep your blood pressure down, if you start to exercise and so on, you keep that ratio at 3:1 as opposed to it going now 4:1, if you understand what I mean. So it doesn't necessarily go back to the normal ratio of the heart on a chest X-ray, or the ECG reading doesn't change. It doesn't stop showing left ventricular hypertrophy, but it doesn't worsen if the right things are done.
Okay. Okay, have another question, Kathy?
No, I wasn't. I don't have any more from my end. You can go ahead if you have more.
Okay, great. Yeah, Dr. Boyce, there seems to be an increase in sudden death syndrome, people getting heart attacks, and some people are saying it might be related to COVID, how COVID affected the body negatively. What's your view of COVID causing sudden death? There's an increase in heart attacks in Barbados.
So there is evidence that COVID does affect the blood vessels, and that there can be an increase in heart attacks and sudden death. However, if we think back to pre-COVID times, there have been times where we've had newspaper reports of persons standing at the bus stop and suddenly falling and dying. So sudden death as a result of heart attacks is nothing new, but there still needs to be more studies about the degree to which COVID causes heart attacks. Early studies, because remember, COVID was 19 and this is 2023. November this year is going to be 4 years. So this is still a relatively new disease, but evidence so far is showing that there have been increases in the rates of heart attacks, and there is some evidence that it can be attributed to the COVID-19 infection. But the important thing is you try your best to be as healthy as you can. I think that's the most important thing. Those modifiable risk factors, if you can change those risk factors to put the odds, as it were, in your favor, then whether or not you had COVID or whether or not something else comes around that knocks us out, God forbid, you would be able to be, I want to say, resistant, or the effects wouldn't be as deleterious or as severe as some person who had those modifiable risk factors and did nothing about them. And the important thing, again, is that you are alive today, which means that you can make a change today. Any change in a positive direction puts more odds in your favor. Some studies are showing, for example, with weight, even although we want patients to lose weight, we're still happy that patients aren't gaining weight. So that's a small victory to celebrate. And that shows that you're capable of losing weight. So yes, There's COVID affecting the heart. There's long COVID, LONG, meaning that there are long-term effects as a result of COVID. But remember, heart attacks are not the only cause for sudden death. There's so many other reasons for sudden death, like pulmonary embolisms, clot in the lungs, stroke, or which can either be ischemic, meaning a clot in the brain, or hemorrhagic, meaning a bleed in the brain. So all of these are possible causes of sudden death. I mean, there's gunshot wounds, stabbings, all causes of sudden death. But yes, to answer your question in short, yes, COVID has caused an increase in heart attacks. And you know, one of the other things that could have possibly led to the increase in heart attacks, you see, now this is why studies are important. Now, based on the lockdowns and restrictions that we would have had, persons were avoiding going to healthcare institutions. And what would have happened would have been persons ignoring things like chest pain, because if you know how many Bajans die from gas, everybody in Barbados dies from gas. Gas moves from here to there and everywhere. But those persons who were avoiding going to the hospital, who had hypertension, for example, they would have ended up going in later stages. So these aren't persons who are necessarily infected with COVID, but these are persons whose hypertension was out of control, or persons who didn't know they were having heart attacks. And therefore you would get increased numbers of heart attacks in looking at the numbers of heart attacks as a result of persons not accessing care. So that's another reason for seeing increased heart attacks and strokes during the COVID time.
Okay, I have another question. Colleen is asking, is it dangerous to mix use of prescribed high blood pressure medication and alternative medicines?
It's dangerous to mix any medications. It's dangerous to mix alternative and alternative, prescribed and prescribed, or prescribed and alternative. And this is where the pharmacist is a valuable individual, because they are more in tune with the drug interactions. There are drug interaction checkers which are available, which do show which drugs ideally should not be used together, both alternative and commercial. But it is dangerous to mix things about which you're not certain, which is why one of the reasons when you go to your healthcare professional, one of the questions always should be, are you taking anything over the counter, or are you taking any alternative remedies? Because there are drug to drug interactions, some of which can be very serious, some of which can be fatal. So it's always important to let whichever healthcare provider you're going to, it might be the person who's doing alternative medicine, it might be your general practitioner or a specialist, you must let them know everything that you're taking, including multivitamins. Sometimes we don't think about multivitamins. And certainly your alcohol consumption as well, because there is alcohol interaction with certain medications as well. So before you take anything, have that discussion with your pharmacist or the discussion with your healthcare provider.
Okay, thank you, Doctor. There's also a question about high cholesterol and heart attack. How does high cholesterol causes heart attack and pulmonary embolisms? Those two things.
Okay, let's do the first one. High cholesterol is associated with forming plaques in the blood vessels. Now, normally your blood vessel looks like this, where there is free passage, if you can see my finger, free passage or flow of blood throughout that vessel. Damage to the vessel wall and the deposits of cholesterol and platelets, that leads to plaques being formed. Now, the thicker the plaque, that reduces the diameter of the blood vessel until it reaches a point where blood cannot get through that blood vessel, and therefore the tissue that's supposed to be served by the blood coming through that blood vessel will die. And that is what a heart attack is in the coronary arteries. You can also get plaques ruptured and emboli, or pieces of clot going into blood vessels. Now, this differs from pulmonary embolism, which occurs in the blood vessels in the lungs. So they're two separate conditions, right? If we think about deep vein thrombosis, for example, there are persons who have risk factors for developing clots in the deep veins of the legs. And these can break off and go into the lungs, and that causes a pulmonary embolism. If persons, for example, have cancer, or they are missing certain proteins that predispose them or make it more likely for them to form clots, then these persons are the ones that are going to develop the clots in the veins, and they go into the lungs, and that's what causes the problem. So two separate conditions.
Okay, thank you so much. Any other questions? Your side, Sister Kathy?
No, please.
Okay.
Okay, well, let me take this opportunity to say thank you for allowing me into your homes. I hope that the information that I provided has been useful to you. And if there's one thing I want you to take home, is the need for conversation and discussion with your healthcare provider. I think that above all is the most important thing, because so many problems could be solved if there was more conversation and teaching and understanding, teaching and learning. We learn from you as well. So that conversation is the most important thing, I think. So make sure the next time you visit your doctor that you sit down with your pharmacist or your specialist, that you have a conversation and you find out what you need to find out. And by closing, let me tell you something very simple. I had an elderly patient and we were talking about her medication. So I was counting her pills and I realized that she was not taking her medication. And the reason why she wasn't taking her medication is because she took the desiccant, which is the agent inside the drying thing inside the box, so that the medication doesn't become soft and dissolve. She was trying to dissolve that in her tea. And because she couldn't get that done, she decided that it didn't make any sense taking any of the other medications, something as simple as that. So we as healthcare providers have to be very careful about what we tell our patients. So we just can't go and say, go and take your medication. I mean, I didn't ever in my life think that I would have to say to a patient, don't take the drying agent in the medication, but be that as it may, it's instructive. So you need to make sure that conversation is had. And thank you once again.
Yeah, thank you so much, Dr. Boyce. And we also want to say thank you to Sister Kathy and Sober Express for joining us tonight. And we hope that you have been blessed and encouraged. I know that we have learned a lot tonight. What we have heard have been very interesting. And I'm sure that everyone received it well. And we hope that this timely discussion tonight will help encourage you to pay more attention to your heart health, making sure you get sufficient exercise, watch your diet, drink sufficient water, and take your vitamins, and make sure that your heart will last you a lifetime. Will get you to 70. So God bless you, and I pray God will bless all of you. Our final session is on Saturday coming up on the 24th, a fun family event. So God bless you. Have a wonderful night. Good night, everyone. God bless you.